Welcome, everybody. I'm Allie Orwig. I'm with the Indiana Rural Health Association. We appreciate you joining us today. We've got a really excellent and I think dense presentation today, and I want to get to that as quickly as possible. But I do want to do a couple quick housekeeping items. The first is that we are recording today's session. If you need to leave during the program, or you find it to be the most amazing thing you've ever seen and you want to share it with colleagues, we will have that available on our YouTube channel no later than tomorrow. We also will be taking questions during the presentation, but we are going to save those for the end in the Q&A session. You'll be able to submit those either using the chat or Q&A functions, which you can find by hovering your mouse over the screen. They will pop down either from the top or the bottom, depending on which view mode you're in. If you would rather ask your question verbally, we'll ask you to use the raise hand function when you do that, and we can unmute your line. Without further ado, I'm going to turn it over to my colleague, Nicole Watkins, to introduce our speakers today. Nicole?
Thanks, Allie. Charles and Kate are just such staples of the RHC community, and if you haven't heard their names before, hopefully you get to meet and chat with them today, but also just kind of be aware of their expertise. So they are just really great friends of RHA, and we're so thankful to have them being willing to be here with us this morning or this afternoon, I guess, rather, just to talk about how to structure an RHC, and then Kate will go over kind of the survey portion of that. So without further ado, I will turn it over to Charles. I believe you're starting.
Yes, thank you very much. Boy, we were just talking about French Lick. I think I'm on my third version of French Lick and the appearance of that facility and coming to IRHA events. So hopefully we'll see you all in French Lick. It really kicks off summer in a lot of ways. It's a beautiful event. So please make sure and come join us. I'm here with my esteemed colleague, Kate. Thank you for the kind introduction. Kate and I have been around the RHC block a few times. That is for sure. We also work very closely together to help make sure that rural health clinics get off to a good start. We're here to talk about two aspects. I'm here to talk about configuration of the business and administrative side of a rural health clinic and how to get that started off correctly. And then I'm going to hand off to Kate to talk about what needs to happen in your rural health clinic. So let's get started. I'm going to breeze over some of the basics. Why are we here? What's provider based? Really want to focus on what the process looks like post survey and some of the configuration things we need to think about, of course, at the very beginning, but really that NPI administrative processes in order to start billing correctly, so you don't have to go back and redo a bunch of things before you can start billing. I really want to focus on this question of holding claims upon survey and certification. It really trips a lot of organizations up and ends up costing significant money if you're not careful. So, what is an RHC? Ostensibly, we all know why we're here. To better our RHCs, been a lot of changes to the program. This program was written, established, signed by President Carter in 1977. When I describe where as a child, what some of the characters, I say as a child, of mental health care in particular in the 70s and 80s, think how much change has happened in just the way we talk about things, much less what all of these administrative processes have taken on. So signed into law in 1978, signed into law in 1977, in order to establish a special type of reimbursement, actually is part of a lot of our problems. It's a separate payment type for primary care providers in rural underserved areas. So think about what an isolated rural nurse practitioner run clinic in Appalachia would have looked like in the 70s and the technology available to that clinic in the 70s versus now. And of course, it's been a sea change, and there are a lot of things that are irrelevant now, but that we still have to deal with because it's part of our regulation and part of the structure of the program. So we're here for that that different payment model, which is a different topic for another day. We're here because we want to get enhanced reimbursement to be a rural health clinic. The rates look like this. We just went to $126 at the Medicare level. The Medicare Modernization Act established this rate structure. The rates are going to go up $13 per year until 2028, when we roughly equalize with FQHCs. And the benefit of being a provider-based clinic has largely been eroded for newly established rural health clinics. So all of the previous conversation we used to have about uncapped and capped has gone away. It's been a big industry change. So when we talk about structural issues, unless you're, there were major incentives to make sure you're a provider-based rural health clinic that aren't available now. And there were huge dollars spent on converting a practice to comply with provider-based provisions that, unless you're a 340B, unless you get a lot of money from 340B, provider-based doesn't offer a lot of benefit now. Productivity standards, we're not going to focus a lot on this. Got to have a minimum productivity standard. This does not mean when Kate comes in and surveys that she is going to check to see if your physician saw the one full-time equivalent of 4,200 visits and your nurse practitioner, non-physician providers saw 20. That doesn't get looked at during surveys. It's not a compliance issue. This is a cost reporting issue. And that's prorated based on the number of FTEs actually spent. So when you're calculating the number of providers you've got, make sure and pay attention to the FTEs. One full-time equivalent is 40 hours per week per provider, and no providers are one full-time equivalent. Most of them are 0.8, many are 0.6, part-timers are probably 0.3, 0.4. It gets prorated on the cost report, and it makes a big difference there. It's not a compliance issue, but it's something to definitely pay attention to. All of the rules, when you look at the listserv, when we talk about how do we structure things, what laws do we have to comply with? State laws make a rural health clinic in Missouri very different from a rural health clinic in Indiana or Illinois, for that matter. State laws affect providers, physician supervision. Kate's going to talk some about what public health emergency effects there are with that lifting on supervision and providers being present. But just remember, when you have a question, hey, what's the requirement for my physician supervising my nurse practitioner? That is state law. And at the Medicaid level, we have 52 different ways to apply to state Medicaid agency as a rural health clinic, and that has a dramatic effect on the time frame to get into the program, as we're about to see. Independent RHCs, those hospital less than 50 beds or not associated with the hospital. Provider-based is not just a clinic owned by a hospital. It's a clinic that is on the hospital cost report and shares the hospital EIN. So just because a clinic is owned by a hospital does not mean it's been attested and complies with all provider-based requirements. But technically, a provider-based clinic is one that is administratively, financially, and operationally integrated with the parent hospital. And there are a number of tests to prove that. The big issue for you as rural health clinics, here are the interpretations for how the provider-based payment regulations are interpreted. This document has not been updated since 2003, but it provides the sole source of answers we have for things like, what if my rural health clinic's further than 250 yards from the hospital? How do I have to be financially integrated, et cetera, et cetera? CMS A03030, it comes up automatically on my machine, I can tell you. And the biggest trick to remember structurally, why I'm bringing it up here, is a provider-based rural health clinic is not an outpatient department of the hospital. It's a provider-based rural health clinic. I repeat, it's not a hospital outpatient department. There are big ramifications of that, such as EMTALA, such as space sharing considerations, such as a lot of important ones that are not impacted, distance from other provider-based locations that are not impacted if you're a provider-based rural health clinic, but would be, let's say you have an outpatient rehab unit you put in a remote town, you're subject to everything that a hospital outpatient department would be. A provider-based rural health clinic has a different set of rules because it's not a department. Just to reinforce that, it comes from 42 CFR 41365. It's some super sexy reading. I highly encourage you all to look at it. If you want to know what I'm talking about, it says right there in the definitions at A2, department of a hospital excludes rural health clinics and FQHCs. Big issue. Fee for service, we're talking about fee schedule 1500. Different payment mechanism we know are Part A claims. We're institutional claims. We get we're different payment methodology. And so we file all of our claims on a UBO4 using cost reports and revenue codes to establish rates and report our services. Big issue, can't understate it. Different payment methodology altogether. So start planning for the different payment methodology at the beginning of your conversation about how do we convert this. Start talking about getting set up for UBO4s. Can your software handle it? Get ready for claims in addition to those 1,500 claims that we talked about. Your Medicare and most of your Medicaid claims, but we could split that here. Going to be institutional claims. Medicare Part A, UBO4, type of bill, actual charges. We're not submitting our encounter rate. These are all billing questions, but just as you know, a big structural issue for patients is to get your patients to understand that once you become a rural health clinic, just a little bit of education with them goes a long way, and say, hey, we're changing the program participation. We're a rural health clinic. Now your coinsurance and deductible amounts are going to be based on your total charge. That's why we don't submit the encounter rate on a claim. We submit our total charge. Coinsurance is based on the total charge. It's not based on that Medicare physician fee schedule allowable amount. Medically necessary diagnosis, blah, 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 big issue. Our firm advises rural health clinics to get a new RHC NPI. Other consulting firms, and depending on the state, do not. Our recommendation is when you start the application process, get a new RHC NPI and report that on your 855A application and subsequent Medicaid MCO applications as a rural health clinic. There's just as strong of an argument to amend your legacy NPI with rural health taxonomy and don't add a new RHC NPI. Our firm takes the other approach. There are pros and cons. Do you get a new RHC NPI with only RHC taxonomy, or do we amend our current, I'll call it legacy NPI, to add RHC taxonomy and just keep one NPI number? In the provider-based days, it was you get a separate NPI because you're going to have mixed payments, period. Now that we don't have provider-based, there's big of an urge to do that. It's a little different of an issue. But here's the big thing. For example, in Ohio, the Medicaid agency, you can only have the RHC taxonomy on your RHC NPI in order to apply as a rural health clinic. Other states aren't like that. Still, our advice remains, we think we should get a new NPI. It keeps your payments much easier to report and keep track of. It reduces mixed payments. The negative is on those states, you don't have to get a separate RHC NP taxonomy. Okay, fine. I'm not then required to have a second NPI, but having a second NPI definitely creates crossover problems. Because when you cross over from your Medicare rural claim that has an RHC taxonomy to your Blue Cross Blue Shield that has you enrolled with your legacy NPI, it absolutely creates problems. So that's something to communicate at length about with your consultant. And it really can just vary what the needs are per clinic of whether or not you do a new NPI or you just keep your old one. But this is a big consideration of how you configure your NPI numbers. I'm not going to focus on this slide. There's a lot of detail there, but this really tells you Medicare RHC, where the claim goes, where the provider number is, what NPI, what EIN. A little bit of a chart. Our commercial over on that right-hand side, commercial should just stay untouched. Don't do anything with commercial. There's no need to touch any commercial provider number. Commercials don't care that you're a health clinic. And so just if you choose not to get a new NPI, just make sure you don't screw up your existing one, because then you screw up all your other payers. That's another big incentive for just getting a new NPI. Don't mess with any old enrollment, but it's a philosophical question we won't solve here. Your rural health clinic money is not subject to MIPS. You don't get upside of MIPS, so you don't get the bonus, you don't get the penalty. Largely, rural health clinics have not qualified for MIPS because this is all based on our 1,500 revenue, of which we typically have little, unless we have a provider that has a large hospital or fee schedule practice someplace else. We might qualify for MIPS, but this conversation is getting pretty antiquated because most of us are hopefully joining ACOs, which exempt your rural health clinic from MIPS. I know a fine one called Rural Advantage. That's us. We've established an ACO for rural health clinics so that we know how to leverage the rural health clinic claims for shared savings, because if your ACO doesn't know how to tell you to bill, you're out of luck, especially as a rural health clinic, because we have different annual wellness visit billing than everybody else. So MIPS, not affected. You can participate in an ACO, and that is separate from your rural health clinic claim revenue. So MIPS and ACOs, conversation to have. You have to start with an 855A. 855A gets you started. Medicare can take up to 60 days to approve the 855A. So once you have an approved 855A, there's still a lot of stuff to do. Namely, that's when Kate takes over. Kate and her crew, compliance team, or whatever accreditation organization you use, you may use Quad ASF, they typically don't do anything and come on site until you've got an approved 855A. 855A is not an 855I or R, it's an 855A. And once you get that, it's a recommendation for approval pending survey. The 855A alone can take 60 days. The only other two applications that there are really for rural health, you could probably quibble with that, are the CMS 29 form, which goes to the State Department of Health, and a 1561, which goes to the state as well. These percolate up to CMS and Kate, and they all get this information. And it then at the regional office is where this all gets on file and coordinated. There are a lot of back and forth up and down from CMS regional office to the State Department of Health, the accreditation organization. They're all talking about the information on these three forms. And it's what the basis of your RHC approval is. And if you notice here, I have circled on the CMS 29 form, that's the only place that indicates whether or not you're affiliated with a hospital. It's really important not to answer that yes, if you're an independent rural health clinic, of course, but that's the only checkbox that says whether or not you're really provider based. There's some other information on the 855A. This is a really important form right here, and it really has to change anytime your medical director changes. You should submit a new 850, or excuse me, CMS 29 to the state, because that keeps everybody up to date. Let's talk about the timeline, and I'm going to turn it over to Kate. After the survey, the whole process after the survey can easily take 30 days to get all the way through it, depending on the state you're in. Don't count on that and don't plan on it. If you're in Texas, it can take 180 days just to get the provider number. So you have a lengthy process after survey until you're ever ready to bill. So do not just plan on starting to hold claims as soon as you get your survey. Just the survey process from, okay, well, here's the 855. This is kind of an estimate because you can do a lot of these things up front, have Kate and her team ready to go and in place once you get your 855 approval. So work ahead of time absolutely benefits you. But the survey process, RHC survey, respond to deficiencies, get the approval from the compliance team, easily take 60 to 90 days there. We're here to talk after the approval date. Once the AO compliance team notifies the state, can easily take 60 days to get the provider number. We're Indiana, we come out of Chicago. It's taken 60 or 90 easy just to get the provider number. It's going to take, once you get the provider number, they've got to hand it off to the MAC. They hand it off to the MAC, they establish a rate. It's going to take at least 30 days for the MAC to get you set up once CMS hands it off to them. And then here's the killer. You typically can't apply for Medicaid MCOs until you have an approved Medicaid application. So first you got to apply with straight Medicaid, and then you can start with the Medicaid MCOs, and you're way down the line at this point. So there is no holding claims immediately on survey. When you get issued a provider-based provider number, it is not an assessment of your provider-based compliance. It says on your CCN issuance, this is a provider-based number. It doesn't mean you've been determined to be in compliance with all the provider-based provisions I highlighted a few slides ago. People get themselves in big trouble on this. Kate and her team do not do a deep dive on provider-based anything other than making sure all the signage matches up, really. And so a provider-based provider number does not mean you've passed a provider-based attestation. A provider-based attestation is the only way to say, yes, we comply with all provider-based provisions and CMS has approved it. And that happens through your MAC. You can't have more than one EIN operating out of your rural health clinic space at a time. So for example, your hospital, you got a physician medical group under one EIN. We've got the hospital that we've done the RHC certification under the other EIN. It can't both be billing at the same time. Whoever owns that EIN is who's billing out of that space. I know everybody's going to raise a question about carve-outs. This is why we don't like carve-outs. This is not the same as your non-rural health clinic lab, et cetera. We've got some different provisions there, but in your rural health clinic patient care space, one organization is operating out of that space at a time, period. We can have multiple NPIs operating out of the same space. Some people on that NPI consideration, some people think, oh, I can only have one. No, you can have an NPI that's set up for your commercial and have an NPI that's set up for your Medicare, Medicaid, but you can't have two different organizations at the EIN level in there. That is when we get into commingling. Talk about the timeline for converting to RHC claims. Once you become an RHC, once you, first of all, out of the box, don't change anything with commercial. We're not going to touch your commercial enrollment. We don't want to. We don't want to disrupt any cash flow over there. Plan early on your claim conversions. Don't start talking about holding claims once the survey happens. Start talking with your consultant about holding claims when you start the whole process. You will not, if somebody's telling you to hold claims immediately upon RHC approval, get somebody different to listen to, because that is not you'll kill your business. You, as on my chart, you saw you will have a long time before you're ready to bill RHC. So continue billing. Check your UBO4 capacity at the beginning of the billing process and set up your billing at the beginning of your RHC conversion and have a plan in place for once you become. Here are some considerations for when and whether to hold claims. You start from the survey date, your cash flow is going to stop. Because your Medicaid MCOs, we can't enroll, man, it may be 150, 180, 210 days before we can even submit a Medicaid MCO application. So you've automatically got a massive pile of timely filing right there. If you stop submitting claims for Medicare and Medicaid when you become a rural health clinic, don't do that. So I've got a few hints about when to hold claims. Our recommendation is for Medicare, start thinking about it. I don't like to hold claims at all. If you have to hold claims, start on Medicare when you get the Medicare provider number. But Medicaid, don't even start thinking about holding any claims until at least you've got your MCO applications filed, because you will incur timely filing losses. No question about it. What I like to do, what we like to do, is set a forward date. Okay, we know this forward date, everything's going to be aligned. The billing's all set up. The enrollment's all set up. Medicaid MCOs are all set up. We're going to flip the switch and be able to submit all of your claims as immediately as when you flip the switch as possible, excuse me. Your Medicaid MCO claims are never going to get paid retro, ever. They're not going to recognize your RHC approval date. They will, if you're lucky, recognize the date you submit the application. So you have a window of loss in there. I've seen organizations incur millions of dollars of losses, and I had to sit on my hands and my stuff socks in my face to say, I told you that would happen. So holding the claim process, talk to a professional. Non-rural health clinic services, I'm not going to talk about that. Remember, those are separate. That's a different payment methodology still. And if you're provider-based, those provider-based claims get paid. Lab claims, provider-based lab claims get submitted under the hospital. Here's some of the configuration. The biggest point I wanted to talk about with, man, that holding claim conversation is just so critical. Terminating an RHC, people call me and ask me how they do this. I never like to do it. So I would say, are you really sure you need to terminate it? But it's actually pretty easy to do. You file a terminate 55A and you have to file a terminating cost report. But here's the thing. Termination is not temporary. Once you terminate it, there's no getting it back ever, period. You got to go through the recertification process. We've seen it happen. I thought I turned the termination and I thought it was temporary. Once you send a letter that says, I terminate this, it's terminated. You're over, it's out. So it's easy to do, but it's impossible to take back, like so much in life. So I am going at this point then to turn it over to Kate. I'm going to let Kate go through the survey particulars, and I'm stopping my share.
You don't want to stop your share. You want to.
Oh, I do want to keep my share. I'm sorry. I'm not used to doing it this way. I'm sorry. Let's come over here. And
There we go.
am I getting better?
Yes, you just have to make
And
it
now-
screen. There you go. There you go. Okay.
Great.
All right, let's see what's before that. Was there one before that? I think so. No. Okay, so let's start out real quick with what ends. And hi, everybody. And guess what? Charles took, I can't do it. I can't teach RHC compliance in 10 minutes. It's just not going to happen. So here's the deal. Come to Indiana on June 13th and we'll talk about it there. Okay, so we'll do as best I can here in the short amount of time. And all important stuff, it's just tough to cover in an hour. So on May 11th, the 50% non-physician provider in the RHC that was not applicable during the public health emergency ends. So if your NPs and PAs aren't in that clinic 50% of the operating hours, on May 11th and you get a survey, you're out of compliance. Okay, so just remember that. Alternate locations ends that day. It's done. If you're seeing patients in another spot right now, that ends on the 11th. That spot can be there, but it's going to be fee for service practice, not a part of your RHC. The documentation for physician oversight ends on May 11th. Okay. Oh, no, I apologize. That one, that's unusual. They extended that to the end of the year. I don't know why, but they did. So if you're not getting your oversight charts written up and signed off by your medical director, you have till the end of the year to do that. Now, telehealth extends till 12/31 of 24. What is not clear is where the provider is. And I actually asked that question of CMS this morning and did not get an answer yet, because that is very important, because the place of service is not the physician or nurse practitioner's home where they might be doing telehealth today. So just beware that we got to have an answer on that one when the time comes. So, all right, so let's roll. 491, 42 CFR 491, 1 through 12 is where you find the laws, the rules for rural health clinics. And I've given you them here purposely so you have them. Many people don't really know what the law says. You need Appendix G as well if you're surveyed by the state. If you're surveyed by us or Quad A, our standards are approved by CMS. We can make no changes without their approval, so you don't need Appendix G. But state surveys, you absolutely do, which is one of the issues with state surveys. You really want to be with an accreditor. It's much more defined, consistent surveys every 3 years, and you're good. You don't risk losing your billing number. You're not a licensed state, so we'll roll right by that one. You just need to keep your organization's licensing organized. So because someone didn't renew their license, and we've had it happen, and yes, it's their responsibility, but you get the ding. They don't get the ding. Okay, so remember that. The location of the clinic. This is another hot button that we're not going to discuss right now, and that is the new census definition that took away non-urbanized. And so we're waiting on the memo. I asked that question also today, and they say the memo is coming soon. I don't have a definition of soon, but we are waiting. Now, in the last couple of years, you can add a mobile unit, and there is USDA money for that right now. If you don't know about that, to add a mobile unit to your existing RHC, think of it as an extra exam room on wheels. It goes to 5 locations through the week or 10, all in a HIPSA, and all posted on your website, on the van itself, on the door of the clinic, that there's a mobile unit, and it's out at 4th and Vine every Tuesday afternoon, like a bookmobile. And it works really well when you use it properly, and it can work really, really well with a school. So there's a lot to think about with that, but still in rural, of course. That is a good process. You do not have to have everything in that mobile unit that you have if your mobile unit is its own independent RHC. So again, think of it as an exam room. You have what you need in that unit as it rolls around in your county, okay? Now, and all these changes, if you are already a rural health clinics, you're grandfathered in for the HIPSA removal, for the population thing, all of that, you're good. So it's only for new and when you grow and expand that you need to worry about those things. So we're not going to go, I'm not going to spend any time on the HIPSA right now because it's still up in the air. We'll just leave it there for now, okay? Your clinic is constructed to take care of your patients. That makes sense. Most importantly, drugs and biologicals are appropriately stored. This is your most robust policy. How do we keep our drugs safe? Do we always dispense out of original containers? On and on and on. Do we have logs and lot numbers? Is a lot number recorded in the EMR for those drugs that are administered in the clinic? Very, very important. Do we have a log for samples? So if there's a recall, we know where it went, and we can call that patient up to destroy that drug or bring it back into the clinic. Clean and orderly, of course, is very broad. And it wasn't until we got the COVID part of 491.8 that we got a little more broad on that in terms of infection prevention. And I'll talk about that when we get there. For now, you think of clean and orderly, just what it says, clean and orderly. Must be under the direction of a physician, you know that. There is no waiver. I get this question a lot. There's no waiver for medical director. You write and tell the state or the accreditor that you lost your medical director, and you show good faith to find one. But there is no waiver for that like there is for an NP or a PA, all right? Your staffing. So you have a staff that includes one or more physicians, one or more NPs or PAs, or perhaps a certified nurse midwife. One of those types must be in the clinic at all times the clinic operates. Now, if there is no one in the clinic, then the patients don't get past the front desk. So we don't do blood work, weights, blood pressure checks that people could do on the way to work in the morning. We cannot do that if there's no provider in the building. I will say this, it says in the law, physician assistant, nurse practitioner, social worker, clinical psychologist in the clinic, not a chiropractor, not a podiatrist. They cannot see patients independently in a rural health clinic. I would love to see that changed, but right now that's the way the law reads. So we cannot have them seeing patients alone in the rural health clinic. There must be one of the other types of providers in the clinic. And that's 50%. So that's waived at the moment, but that's going to end at the end of the pandemic. And so the 50% includes admin time. It could include her visits to swing beds in the hospital, which she can round on, and it can include nursing home visits, but you must document that time. So you're proving if somebody's on the line at 50% that they are fulfilling that obligation. The physician has responsibilities for everything that happens in the clinic. The buck stops there. So he does oversight of the clinic. And that is only documented in terms of chart review. What is your number? What do you have in your policy? Does it match what you're actually doing? And how do you show the surveyor? Okay, we chose 5 charts a month. And so here they are. Here's the 5 patients signed by an MD, and we move on. And it's that simple. But you must match your policy to your actual work. And that's true of so many policies. This very week, we had to cite someone never went back and changed their policy on their biennial evaluation, and it said annual. Well, that's what your policy says, and you're not doing it. So it's a simple citation. It's not a failed survey, but they need to change that policy because they're not doing it every year. They're doing it every 2. Actually, I kind of think you should do it every year, but that's just me. Who doesn't look at their business? And I'm getting off track here every year. And the folks like Charles can do that sort of work for you. You don't even have to do it yourself. So the PA and NP also have responsibilities, and that's to collaborate with the physician on patients as needed and to transfer patients appropriately and to the extent that they can't care for them in the clinic. Now, vaccinations. So we're still at 100%. This is not a waiver. This is not going away unless there's a law change. So everybody in the clinic has to be vaccinated. What does 100% vaccination mean? It means vaccinated, religious exemption, or medical exemption. And for the religious exemption, you have a policy. Nobody's going to question that signature that Kate Hill has a religious exemption. If you have a policy that says, here's how we determine that, nobody's going to question that and shouldn't. Now, medical exemptions go by the CDC, and what that says is a good medical exemption signed by an MD or NP or PA. They can also sign those. So that's what 100% means. But you have to have all these policies, and I certainly don't have time to read them all now, but the policies and procedures on how you track, and you must have a log on, it starts out with the names of all the staff in the clinic, those that are vaccinated, those that are medical exemption, those that are religious exemption, those that are boosted. You must track boosting. It's right in the law. It does not require you to have a boost. I don't think anywhere but California, I could be wrong on that, but California does require the booster, but most states do not. And so you must track it. That is written into this law. This law snuck in so fast it made your head spin, but it is in 491.8. There's no getting around this. This is not going away unless we get a law change, and not going to opine on that, whether that would ever happen at this point in time. And then, so documentation is important. I want to pull out the tracking is critical. They're going to look for the tracking. There are contractors right now hired by CMS, not accreditors, contractors, who are doing COVID surveys around the country in rural health clinics. Some of our clinics have gotten hit with this. And so they're looking for that tracking log. It really is an Excel spreadsheet, but make sure you have that. And the other thing on the spreadsheet would be on hold, medical hold for some reason. Maybe they're breastfeeding, maybe this, maybe that, whatever the reason is that the physician feels they shouldn't be vaccinated at that time. And I wanted to talk, I missed it, but the place where it says you are following nationally recognized infection prevention control methods in your clinic. That's in 491.8, and I just went by it. But that's where it comes now, that how we are controlling spread of infection in our clinics. That's in the regs now at this point. All right. Obviously, all your services are provided in accordance with the state laws. That goes without saying, without any question there. Your patient care policies must be complete. You must have instead of a book on every disease known to man, have a verifiable reference. For most of you, it's up to date. We hear that every day, but up to date then would be in the policy on where they look up the different things. And then that's signed by the medical director. So he's agreeing that up to date is a good source for looking things up for different diseases and whatnot. You must have that. Otherwise, you need a policy on every disease known to man that we'd ever see in a rural health clinic. And we really don't want to do that. Now, all policies are reviewed biennially. That's every 2 years by this group of professionals. That's 3 people, an MD or DO, an NP or PA, and an outside person, someone that's qualified, should be a professional that does not work in the clinic. Provider-based clinics, it's pretty easy because you get the quality control nurse or a doc from the hospital or the risk manager, somebody who's trained that can read your policies and sign off on them. You independent clinics have to find someone, it could be your local pharmacist, a doc in town or something. As long as they don't work in the clinic, it works to have that signature. So that's a signature page that goes in the front of your binder, whether that be physical binder or electronic binder. And that date is never more than 2 years ago when a surveyor walks in the clinic. Very, very important. Don't miss that. We're missing that a lot right now. I think because people have just been through so much and that just got by people. Any policy that you update in general, of course, you need to update it with the date. Now, this is something we've never cited. This says a rural health clinic does medical history, physical exams, health status, and treats a variety of conditions. We have never cited that. That's exactly what you do every day, and we thank you for that. The lab. So we're hoping the next law is called the Burden Relief Act. It was supposed to be in the Medicare Modernization Act, didn't make it through. We want these 6 tests to go away. We know that this is pretty archaic. We know nobody orders just a hemoglobin or hematocrit. But remember, this was, Charles said, it was came out in 1987, 78, I think, I forgot. And if you were really, really rural, you needed to know if somebody was bleeding. Well, we just do a CBC now. So, and we can do a stat CBC, and we have labs available everywhere near most all of our clinics. If you need that, you need it. But for the time being, you must have the unit, the HemaQ or something that does that test. And you must have all 6. Now, most frequently, what's missing is the stool specimens for occult blood. It must be the one where it's point of care, where we do the little dropper of stuff on the card and we know if you've got blood in your stool. It's not the one you send home. That doesn't pass muster. And this is in the law to go away. And the new law says labs are readily available. And of course they are. And so we're hoping that will go and save a lot of grief and a lot of purchases of equipment that we don't ever use in the clinic. But you must have the ability to do all 6 of those tests right now today and get a result in your clinic. And your CLIA must be up to date. And all the equipment you use to get a test must be in date and not expired, or you'll get a citation for that. That's a simple part of just the lab thing. Okay. For services are under agreement or arrangement, you don't have to have it in writing. You must prove that a Medicare approved hospital is taking your patients. Very important. You must have an emergency box. What's in it? Thank goodness what's in it is what you, the NPs and PAs and the medical director, know that you need at your street corner. None of these categories here matter anymore. It's what you need. You know that street corner, you know what you need in an emergency box. So put the the list of things in your policy, make sure it matches what's in your box. If you're with us, we want the list by the box, so we make sure they match. Your record system. So this is your patient health records. Who's in charge of that? Who makes sure they're complete on transfer? What is a complete medical record? And I just had this question yesterday. Why do we have to get a new consent every time? Well, you don't. And watch yourself on your policy. If your policy says new consent every year, which you can do, not required, but you can do it, you're going to get cited if you're not getting one every year. And we're looking at 20 patients now per CMS. And so if some of those don't have consents this year, you'll get a ding, and you don't want that ding. So look at your policies, make sure your policies say exactly what you were doing. Okay. And that they're all signed off. And that the other common one here is when you get a piece of paper signed as a consent, and then you scan them in later sometimes doesn't happen. Okay, so let's make sure they're making it into the EMR and we have that consent in the record. And on labs, when you have abnormal labs, make sure your providers are writing a note that Mrs. McGillicuddy was called about her A1C of 14, and there's a plan. We're either going to retest or we're going to put her on medication or whatever. But the plan is in the report, in the EMR, that she was notified. That is critically important. We look for that every time. HIPAA, this is your HIPAA. You know about HIPAA. The most common deficiency is screens that don't log out. And so quick lockout or log out is always the best. But if we walk up to a computer sitting on a counter, we can see PHI, you know that's a problem. Records for 6 years are there I think they're there forever in rural health clinic, in EMRs. Your program evaluation, remember, it's every 2 years, and don't miss that. Missing a program evaluation is a failed survey. We'd have to come back within 45 days. That's tough to get done. You're busy people. That's a lot of work to get it all together. So make sure you're getting that done, and everybody today, go look, make sure their program evaluation is not more than 2 years old. Seriously, that's really, really very important. And we just had one of those last week, and they just missed getting it done. Not acceptable. Now, emergency preparedness, of course, is very complicated, and we're one time for questions. So I'm going to just say 2 things on EP. You need to have an exercise or event every year. So if you wrote up COVID last year, you get to do a nice little tabletop this year and take it easy on yourself. The tabletop must be one of your hazards. What were the risks that you said can happen in Indiana? Was it a tornado? Was it a whatever? But your exercise must be one of the hazards that you've chosen to list in your emergency plan. Don't forget to address volunteers, because it's very important that you address it. You can say, Allie's clinic has made the decision not to use volunteers. That we will accept that, and so will most states. That came over to us from hospitals where there are volunteers. And so if you don't address it, and you think of the surveyor's checklist, they have to mark it missing. If you want volunteers, you'll name them, you'll HIPAA train them, and you'll train them on your EP. And so I think that may be the fastest I've ever gone through the regulations. And I think we should probably, let me just say one more thing. That was the testing. The training is sitting your folks down and reviewing your plan. And you must have a signing sheet. You must show not just a list of names. The top of it says emergency preparedness training for 2023. And there's a list of names and signatures. And that's what you need to show the surveyor, okay? For integrated healthcare systems, you still need almost everything that's in 491.12. You need your own communication plan. You need your own hazards assessment, even if you're in the hospital. So yes, you can do joint exercises, but read that very carefully. You don't want to get dinged on that. Did I do that fast enough, guys?
It was awesome. And I'm sorry I took up so much time. But hey, I think one thing, if we're talking about the structure of a rural health clinic, it's important to talk about the HPSA issue briefly. And we really have 2 different issues happening right now.
Right.
I'll talk about the proposed for withdrawal, and then I'll defer to you on whatever you want to say on the urban versus rural issue. Right now, there are a large number of HPSAs, health professional shortage areas, that are proposed for withdrawal status. You can get an RHC approved when the HPSA is proposed for withdrawal. But once it gets withdrawn, you can't. And then if you do get it approved and it's proposed withdrawal and you want to move across the street, you can't. So right now, I actually have some folks looking for rural health clinics that have had a really difficult time. They were looking for places to put their rural health clinic, finding a HPSA that wasn't in proposed for withdrawal. So those that are proposed for withdrawal are going to be withdrawn approximately July of this year, we think. So if you're establishing a new rural health clinic, what I say to our team is look at the HPSA every time you think about it and see where it is. We also have the urban versus rural issue where the Census Bureau basically eliminated what? The urbanized areas.
Right.
So Kate, do you want to speak on that?
Yeah, so it's all about what's the new definition of rural, and it's going to be by population. So we had a clinic in California denied with a population of 9,000. That's rural. 9,000 is not a city. And so we're hoping that they'll go with at least 50,000, but CMS must put out something on this because in the regulations, it says non-urbanized area. Well, that's what's removed from the Census Bureau report for 2020. So we are desperately waiting on that word, and we'll get that out as soon as we get it. On the HPSAs, back to the HPSA for a second. If you go to HRSA.gov and you plunk in your address and it says proposed for withdrawal, put that down, get on the phone to the state office of usually primary care. I'm not sure about Indiana, but it's usually the primary care office. They're running the HPSAs and they can get working on it. And we've had them turn many of them around in states. So do that today, just if you're looking at a new area. You're grandfathered in otherwise, but if you're looking at a new spot, to Charles' point. And I guess I want to ask if we have any questions. We have 7 minutes.
Well, I've not actually seen any come in. We did ask people to hold them for the end. So if you would like now to, again, hover your mouse over the screen, options will pop down from the top or the bottom, depending on what view mode you're in. You can use either Q&A or chat to send that in. Also, you can raise your hand. If you would rather just ask the question verbally, we can unmute your line. So we'll go ahead and pause now for just a few moments to see if anybody submits a question through any of those 3 different methods.
We'll be sure and send the slides to Allie and Nicole and make sure, I'm sure they'll make the slides.
Yeah, I'll just take a minute here to plug Nicole. And Nicole, if you want to put your email address in the chat for everybody, Nicole is our RHC expert on staff at IRHA. Any questions that you have, obviously, that we've gone over today, she can, pass on to Kate and Charles, any of those questions, but she is a wealth of information beyond even what we've gone over today. So she has now put her email address there in the chat. If anybody's calling in exclusively, it is NWATKINS, so in Watkins at indianarha.org. Still waiting to see if we have any questions typed in to us. And I think based on the time that we had today and just the absolute dearth of information and content that we've gotten, we're going to work with Kate to set up a follow-up session where she may even be able to go a bit more in depth. She has a great presentation, she says, with lots of photos. So we'll get that set up with her ASAP.
Thanks, everybody. Hope to see you in San Antonio. And if not, then in French Lick.
Got it. Thanks all.
Take care.
You, Nicole. Thanks, Allie.
Thanks, Nicole.
Thank you both. Excellent presentation.
Bye-bye.